So here you are watching drug-induced sleep endoscopy with BIS monitoring in a 26-year-old male with history of choking and snoring. He is a mouth breather, as you can see. His body mass index is 30.8, almost 31. Little obese. He has got a deviated septum on the left-hand side. He's got turbinate hypertrophy on the right, which we have decongested. And as we go inside, his sleep study shows his apnea-hypopnea index as 24, 23.5, which is moderate. And as we go inside, we see the turbinates to be hypertrophied on the right side. Nose drop. Okay. So there's a little bit of adenoid enlargement. The salpingopharyngeal folds are not enlarged. They are grade 0 by Agrawal's classification. And as we go further inside, we see a complete collapse of the lower part of the velum. At this point of time, we'll try to go further deep down and see what is happening to the tongue base. The tongue base is also large, and we can see that the epiglottis is also collapsing. So you can see a complete collapse of the lower part of the velum, which is both anteroposterior and lateral. Large soft palate. So you can see sometimes primary epiglottic collapse, as you can see now. Sometimes you can see the collapse of the tongue base. Now I'll try to keep his mouth closed and see what happens. Since he was mouth breathing, so everything was collapsing. Now when I keep his mouth closed, with the mouth closed, you can see here that his soft palate is still collapsing. But his tongue base collapse definitely improves. Not completely, his tongue base is still collapsing in spite of the mouth remaining closed. His palate is completely collapsed. So that is definite culprit, and even his tongue base is still collapsing. Tongue base and the epiglottis are also collapsing in spite of the mouth being closed. But his tongue is not large. So it's just the collapsibility, and his epiglottis is collapsing possibly because of Bernoulli's. His BIS is in the correct range, 70s. You can see the tongue base collapsing here. Complete collapse of the tongue base and the epiglottis also at a BIS of 74. In spite of mouth being closed, his mouth I have kept completely closed, and in spite of that, he's collapsing. So now, if I leave his mouth to remain open, and let's see what all happens. With his mouth open, everything is more pronounced, will be more pronounced. Right now, his BIS has come to 83. We'll wait for the BIS to go down to 70s and see what is happening. So that's the AP as well as the lateral collapse. AP is more pronounced, and at this point of time, if we go down and see now, there is a complete collapse of the base tongue as well. Absolutely complete. So now in the 70s, there's a complete tongue base collapse with the mouth open. The moment we keep the mouth closed, that improves to certain extent, and that tongue base collapse stops and it goes to a primary epiglottic collapse with the mouth closed. The palate is still collapsing. So in his case, we'll need to perform septoplasty, turnoplasty, tubulopalato-pharyngoplasty with suspension bridge, and glossoepiglottoplexy, with the understanding that he still needs to keep his mouth closed. Now see, I have kept his mouth perfectly closed, and then his collapse is definitely better at the BIS of 74. Now his tongue is not contributing, only the palate is contributing. So this is the perfect stage for the assessment. That will be the final result. But still he can have a primary epiglottic collapse that we can take care of with glossoepiglottopexy. We need not perform a tongue-based surgery on him. So septoplasty, turnoplasty, uvulopalato-pharyngoplasty, suspension bridge for both AP as well as lateral, and glossoepiglottopexy. And obviously reduction of weight. His body mass index is around 31. So he has to reduce his weight, that goes without saying. Thank you for watching.